I'm Angie Caliendo. I'm the Executive Vice Chair of the Department of Medicine at the Warren Alpert Medical School. I'm also the Vice President of Brown Medicine and the President of Brown Physicians. My expertise is in rapid diagnostics, molecular diagnostics, particularly around viruses. As our methods for manufacturing tests have become more sophisticated over the years, our expectations have risen tremendously. If you look back at the CDC, it took them about a month to get an assay out there into the state laboratories, which they are now using. The problem is that they are not a manufacturer of testing for the entire country. Their role is to get tests into the state lab for public health use. We rely on commercial companies to develop assays for the hospitals to use widely. And so those assays are regulated by the FDA. And the FDA has altered the regulatory process to make it easier for these tests to get out into laboratories because of the pandemic and the emergency. So they have a mechanism called emergency use authorization that allows the companies to get the tests through the FDA more quickly. Multiple companies and reference laboratories now have tests available, but there's such a backlog of testing. Demand exceeds the capacity right now. And these companies are trying to manufacture as many tests as they possibly can, but they're sending them to areas where the infection rate is the highest. If you're not in what is considered a hotspot, you're not getting prioritization to receive the reagents so that you can run the testing.
My name is Lou Rice. I'm the president of Brown Medicine. I'm the chairman of the Department of Medicine at the Warren Alpert Medical School of Brown University and the physician-in-chief at Rhode Island Hospital and the Miriam Hospital. My career has been spent largely working on bacterial infections. There's nothing that has been proven in randomized controlled trials to be effective as an antimicrobial therapy for COVID-19. There are a number of agents that are under investigation, one particularly called remdesivir that has shown some success against other coronaviruses, at least in animal models, and we have protocols up and running on that drug. There's also another drug and drug combination called chloroquine plus azithromycin, where there is some anecdotal evidence. People think it has worked. There's some evidence that it might reduce the virus in your secretions more rapidly than just standard treatment. The important thing is that we use these drugs in a way that allows us, when all of this is over, to understand whether they actually work. Under the best of circumstances, the mortality rate of COVID-19 is relatively low, maybe 1% to 2% of people who get it will end up dying. And so it will be very difficult to tell whether an agent actually works unless we have good controls of people who are treated, for example, with placebo. If you look at the Rhode Island Department of Health site, and I recommend that people go to that because it's reliable information, of the tests that they have performed, roughly 10% are positive. So you can be reasonably certain that all those people who have been tested actually have symptoms. So we're still at a place in this state where 9 out of 10 people who have symptoms that might be consistent with coronavirus actually don't test positive for the disease. So that's encouraging, but it is out there, and the only way we're going to make this thing go away is by stopping the spread. I mean, that's it. We just have to stop the spread.